We are rounding out week 2 with our second module. And like was mentioned in module 1, we're going to be talking about obsessive compulsive and related disorders. We've already talked about anxiety conditions. So what are the obsessive compulsive and related disorder? Here we're talking about body dysmorphic disorder, excoriation disorder, trichotillomania, obsessive compulsive disorder, and hoarding disorder. Like the other groupings, there are going to be some common features that each subtype in that grouping will have. The common features here are body-focused repetitive behaviors. The repetitive behaviors are often engaged in response to distress or fear, and those include things like trichotillomania as well as excoriation. Trichotillomania is hair pulling, excoriation is skin picking. Let's delve into body dysmorphia or body dysmorphic disorder. It is a preoccupation with one or more defects or flaws in the body that are perceived but that aren't usually observable by others. They're perceived by the individual but not necessarily seen by anyone else, yet they create intense concerns about appearance. Because of these perceived defects and flaws, there's a lot of repetitive behavior that comes in the form of grooming or mirror checking. There are also a lot of mental acts that occur, like comparison. The bodily attention falls on certain areas like the nose, a great part of the time at like 56%, but it also falls on other areas, skin, hair, chin, and ears. This is a condition, body dysmorphic disorder is a condition that is equally debilitating for men and for women, but sometimes in slightly different ways. For men, there is a great focus on skin, like acne or scarring. There might even be an over focus on hair thinning and genitals. Now, I want to go back and I want to say that there is a preoccupation with a perceived flaw that other people don't typically see. So, again, men may see flaws in their skin. They may see their hair thinning or issues with their genitals that aren't readily noticed by anyone else. It's important to state that the human body does not have absolute symmetry, but people with body dysmorphic disorder see a lack of symmetry in minuscule ways: muscle tone, muscle mass, breast symmetry for women. Usually, because of these perceived flaws, the sufferer will adjust their lives, essentially social and professional, to avoid being seen in public. We certainly understand how if a person is preoccupied with their body and they see it as being flawed, that they are going to isolate socially. They're not going to want to present that body that has this flaw to other people. What they will want to do, however, is to engage in behaviors that help to bring along perhaps perfection or the symmetry that they're after. This could result in a dangerous use of steroids. Body dysmorphic disorder is comorbid with other things that we're going to learn about. It's comorbid with OCD because of the preoccupation that goes along with the body dysmorphia, as well as with impulse disorders because of the lack of tolerance for imperfection, which could lead to excoriation, which was the skin picking. When we go back to the mental status exam, which we talked about early on in our classes, one of the things that you assess for is insight. Here is a time where that becomes really important. Patients who have body dysmorphic disorder usually have poor insight. So you want to be able to assess whether or not they understand that their assessment of their body is inaccurate. Okay? That inaccurate assessment also lends itself to higher delusionality and higher suicidality, right? The person is already seeing things that aren't really there, or accurate rather, and they're believing it to be true because of a poor insight. That provides gateway to suicidal thinking, to depression, and even to substance use. Because of the delusional aspect that goes along with this, and the secretiveness, the lack of wanting to expose a grave flaw, this is a condition that can go untreated for decades. This desire to isolate also means that many individuals don't often go out during the day. They may go out in the evenings, or when they do go out, they're always covered up, always with the hoodie, always with the sunglasses. As before, I've included a video that is intended to underscore the topic of body dysmorphia. I do want to add that it won't play here. Go to the complete slides and you should be able to play it there. But when you're watching the video, it may seem funny at the beginning, but it does exemplify how a person with body dysmorphia is constantly preoccupied and sees their flaws everywhere, such that the flaws really become all that they think about. Let's move on to obsessive compulsive disorder, or OCD. OCD requires the presence of either obsessions, compulsions, or both. There was a time when both were required, but in the DSM, it could be either obsessions or compulsions, or both can be present. The presence of these is excessive and persistent and extends beyond what we think would be developmentally appropriate. The presence of the obsessions and the compulsions are time-consuming. They are not occurring because of a medical condition or a drug that the person is taking, and they're not better explained by anything else. So what are obsessions in an obsessive compulsive disorder? Obsessions are the recurrent and persistent thoughts, urges, or images. They are experienced as intrusive, and any attempts to ignore them or to suppress them usually happens via a compulsive behavior. It doesn't have to, but usually it happens via the use of a compulsive behavior. So you have an obsession that you try to quiet with a compulsion. The compulsions, on the other hand, are the behaviors that are performed in response. The obsessions are the thoughts. The compulsions are the repetitive behaviors like checking or hand washing. I have the thought that I have germs. That's the obsession. The compulsion, repeatedly wash my hands. Or the compulsions could be mental acts, counting, checking, chanting. OCD, like some of the other conditions, requires specifiers. You have to specify with OCD if it is with or without insight. Again, this is to that delusional belief that goes into an OCD. You also want to assess their level of insight. Is it good, fair, poor? Is it tick related? Tics can be vocal tics, they can be movement tics. OCD is tick related for about 30% of individuals. Females tend to have a greater prevalence in adulthood for OCD. Men or boys have a greater prevalence in childhood. The mean onset is usually around 19 years old, but onset after mid-30s is really atypical. So this is something that's going to have an early age onset, sometimes in childhood, usually about 19, but we shouldn't see this after 30. If we do, that's unusual. We may want to be looking for reasons why it was delayed until that time. Just like panic disorder, if untreated, OCD can become a chronic condition. As before, this is a video. You're going to take a look at it. This is a day in the life of a man with extreme OCD. You will be able to see how he's impacted, but how, like with the anxiety conditions, it becomes a relational affair. To further underscore the relational aspects and how a anxious parent can then rear an anxious child, I have this video about mothers and daughters, or mother and daughters OCD struggles. So again, when you have opportunity, watch this, because when you are dealing with a parent, you want to be certain to ask about the children. In the previous video, when you're dealing with a spouse, you want to make sure that you ask about the wife. In this case, it was a husband. You want to be sure to ask about the wife, or whomever the spouse or the partner is. This is the last video in this particular module. Some of you may already know about Howie Mandel and his struggles with OCD. Even though it creates a functional disruption in his life because of his celebrity and fame, he's able to engage workarounds, but it is no less functionally impairing for him than it is for other individuals. But his life experience demonstrates the tremendous workaround that has to take place if treatment isn't received. This doesn't just go away, it becomes chronic if not challenged and redirected with treatment. In Module 1, when I was talking specifically about anxiety conditions, I used the word enabling when talking about family members' involvement. I'm going to change that to accommodation because I really think it's the better word. Accommodation is a common problem among family members of those suffering with OCD and with anxiety disorder because the family members often take part in whatever the rituals are, or they assist in helping the person avoid the anxiety provoking stimuli, right? Or they modify circumstances so that the anxiety provoking thing becomes a non thing. Oh, we don't have to go out to dinner. We can just eat at home, right? Would be an accommodation given for somebody suffering with an agoraphobia, okay? The accommodation doesn't force the sufferer to address the issues, and it doesn't interrupt the it doesn't interrupt the exposure and response prevention behaviors, the counting, the checking. When you have somebody that is accommodating, there really isn't a lot of motivation to do anything differently because the needs are still being met, right? However, the the boundaries that get crossed with the person who accommodates become so much more pronounced. Family members may feel forced to accommodate. If we're going to do this thing, I have to do this other thing for you. If the family's going to go out, we have to go out only at night because you don't want to be seen, for example. So, again, when we're encouraging help for the sufferer, we should also be looking at social supports and suggesting help for them as well so that we can disrupt the accommodation that actually keeps the OCD and the anxiety in place. At the beginning, it seemed like I blew past two disorders, excoriation and trichotillomania. I'm going to talk about them in brief here. Formerly, excoriation and trichotillomania were considered to be impulse control disorders, and we will get to that grouping later. However, because they often co-occur with OCD and body dysmorphic disorder, both disorders are now classified with those disorders as obsessive compulsive issues. Excoriation is characterized by repetitive and compulsive picking of the skin. Usually, the picking continues until serious damage results, often requiring some sort of medical condition. And because the skin is now so damaged because of the picking, it adds to a sense of anxiety and depression around appearance. Okay? There is a greater prevalence of excoriation in females than there is in males. Trichotillomania is characterized by excessive hair pulling from the different parts of the body. Again, greater prevalence in females versus males. A prominent spot for hair picking can be the eyebrows. People who are seriously engaged in this more impulsive-like behavior might have no eyebrows, but the eyebrows are plucked, the eyelashes A popular place is usually in the hair because other hair can cover over, and the individual who engages trichotillomania won't then have the additional anxiety of the skin condition being noticed, being bald, lack of hair. So the hair is also a good place. Sometimes the hairline, sometimes at the crown of the head where other hair can cover over. But those are also two conditions. Again, I just went over those briefly. Certainly you may see, if you're treating somebody with OCD, you may see excoriation and or trichotillomania, but these are conditions that are less often seen unless you're really specializing in OCD and obsessive compulsive disorders. The final disorder, and this is the final slide followed by another video slide to exemplify better what is meant by hoarding. Hoarding disorder is the last of this grouping, and it indicates a difficulty with parting with one's possessions. The difficulty is because the person seems to believe that they need to save the items because they think they can be used at some later time or that they have some additional value. Distress is usually pretty extreme when there is the thought of letting go of whatever this possession or saved item is. Because of this difficulty in discarding, we get this accumulation of things that usually overwhelms the person's environment such that they are almost choked out of living in their living space. That becomes clinically significant and distressing, and not just for the person living in the accumulated environment, but for the family members who aren't able to visit, aren't allowed in. The distress also comes when attempts are being made to encourage a discarding. It's important to note that hoarding is not a function of some medical condition, and it's not better explained by symptoms of another disorder. Okay? We're going to specify if this is hoarding where there is excessive acquisition. We're going to state whether or not the insight is good, fair, or poor, and whether or not there is insight into the delusional beliefs that sometimes coincide with hoarding behaviors. Okay, apart from going back and watching the videos, this is going to do it for anxiety and obsessive compulsive disorders. I hope you have a better understanding of how to identify them and how to differentiate them from one another.